Good morning, and thank you for the privilege of the podium. I have no disclosures. As we all are aware as trauma surgeons and people of interest in trauma in the military setting, we know that the FAST exam can offer quite a bit of utility in the clinical context of rapidly assessing an injured patient. However, we also recognize that there are severe limitations to the FAST exam. So most specifically, FAST exam comes with a high false negative rate. And in the literature, this rate can vary widely from 20% to as high as 60%. Interestingly, though, in the patient population that suffers non-compressible torso hemorrhage, NCTH, there's no evidence as far as the test characteristics of the FAST exam. So why is this important for us? Well, if we consider that 2/3 of preventable deaths in Iraq and Afghanistan were from NCTH, this really matters. We should know about the test characteristics of a primary modality we're using to assess these injured patients. So we had a unique opportunity when Dr. Holcomb's group out of Texas compiled a dedicated NCTH database. It was across 4 level 1 trauma centers in Texas. And using this database, Dr. Holcomb's group defined NCTH as one of 3 things. So named axial torso vessel disruption, AIS chest or abdomen score of greater than 2 with shock or a truncal operation within a set time period, or a pelvic fracture with ring disruption. So under this definition, we identified 274 patients that had a FAST exam prior to the diagnosis of NCTH. So I'll stop to note here that if the FAST exam was intermediate or indeterminate or unknown, then we really couldn't comment there. So those patients were excluded. So these 274 patients had a true positive or a false negative exam. The way this was diagnosed ultimately was half by operative exploration and about a quarter by CTA. The source of the NCTH across this population was thoracic in 31%, abdominal in 43%, and pelvic in 26%. And for the purposes of our evaluation, we excluded the 31% that had a chest injury. When we stratified the patients by their location of the injury, so the cavity in which the blood vessel was disrupted, we saw that there were no significant differences across multiple areas. So on average, the patient that we saw was a 35-year-old male that had a blunt mechanism injury, came in with shock, had an ISS of low 30s, AIS score in the 2s to 4s, and went on to have an in-hospital mortality rate of about 28 to 32%. You'll note here that when we compare the abdominal injuries to the pelvic injuries, there was a difference in the FAST negative rates. So if the patient had a prominent injury in the abdomen contributing to non-compressible torso hemorrhage, that false negative rate was 43%, whereas in the pelvis it was 61%. So both are quite large, but significantly different among the 2 groups. And you'll notice the difference between the AIS scores and those with abdominal injuries versus pelvic injuries makes a lot of sense. We then wanted to see what's the clinical impact of having a false negative test, right? Does this actually impact the overall outcome? So you see up top, it says negatives and positives, and I'll again emphasize that because all these patients had true injuries, these are either false negatives or true positives. So across the board, we saw quite a few significant differences, but I'll point out a couple things that were not significant, and this is important to note. So between the patients that had a false negative and a true positive, there was no difference in shock at presentation, in overall in-hospital mortality, the patient's ISS score, or their length of stay. So very interesting that despite what's the clinical implication of having this false negative? Well, a lot of the variables that we look at that matter don't seem to make a big difference. This is a graphical representation of some of the similar data that I've presented before. I'll again highlight that in the abdomen, the false negative rate was about 40%. In the pelvis, it was about 60%, and across all patients was about 50%. So like a coin flip. Oh, and real briefly here. So between the groups, though, whether the patient presented in shock or not, that didn't appear to have a difference. So as far as the discussion of this goes, I think it's important to emphasize that this builds on the literature of the existing data that is out there about the limitations of the FAST exam. We really need to be aware that false negative rates are very high. So in keeping with other data across the board, the 20 to 60% rates that are reported as far as false negative rates go, this is very consistent with that, and in fact at the upper range of that. Of course, this is a study with significant limitations. It was retrospective data. It was a post-hoc analysis of data that was collected for an other study. We were limited to the definition of NCTH as set by the Holcomb group. There were a significant number of patients that had a fast that was either not done, unknown, or indeterminate, so we can't comment on those patients. Again, N of 398 compared to our overall population of about just under 300. So this limits the scope, limits the generalizability, and we should be aware of these limitations. That said, this study does show that the fast identified abdominal or pelvic hemorrhage in roughly 50% of patients with NCTH. It's no better if the patient presents with hypotension at identifying the hemorrhage itself. And it really does lend itself to the fact that we must have due caution when interpreting fast exam results in a patient where you have a high clinical suspicion of NCTH. So on that note, I'll open the floor to questions. Thank you.